Welcome to the GPE webinar series. My name is Jane Davis. I'm Senior Education Specialist for Gender Equality at the Global Partnership for Education. I'm here at the GPE Secretariat in Washington, D.C., joined by my colleagues, the GPE webinar team, who've brought us this webinar today. We're also joined by a wonderful panel of experts here with us and online as well. The webinar series, which started in 2016, is part of GPE's Knowledge and Innovation Exchange, or KICS initiative, that came about as a response to GPE's partner countries' request for additional opportunities to exchange knowledge, good practice, and policy approaches that inform education policies and practices at the country level. The webinar also gives practitioners the opportunity to engage in a continuous practice of knowledge exchange between partner countries, which in turn strengthens and fulfills the national and global objectives of GPE. Before we begin the session, I'd like to draw attention to a few housekeeping items. If you are facing connection issues, please let us know via email at webinars@globalpartnership.org. We will have a Q&A session after the presentations, so please feel free to keep sending your questions throughout the webinar via YouTube's live chat feature or by email. The address is very simple, webinars@globalpartnership.org. We'll certainly try to get as many questions as possible during the Q&A session. Please let us know your name, your organisation, and the name of the presenter speaker to whom the question is directed. The session is also being recorded, and we'll send everyone participating today resources associated with the webinar and a link to the recorded session. As we know, it's the 25th of April today, which is also World Malaria Day. We've also just recently celebrated World Health Day on the 7th of this month. So the topic of today's webinar is extremely timely. The title of today's session is Maximising Human Capital by Aligning Investments in Health and Education. For GPE, we're very much aware that education and health are two sides of the same coin. Healthy children learn better, and similarly, educated children, especially girls, are likely to have better health outcomes both for themselves and their families. A recent survey we've undertaken here at GPE of education sector plans shows that partner governments are also very clear about the benefits of investing in school health, with 52 out of 67 developing country partners including health-related activities in their education sector plans. Also, 22 countries are making use of GPE grants to invest in health activities of various kinds, such as water and sanitation, school feeding, and life skills program. Accordingly, Global Partnership for Education Secretariat is very pleased to host two of our education and health partners from USAID's Bureau for Africa today, with another partner known well to GPE and many of you already, Professor Donald Bundy. In the webinar today, USAID's Africa Bureau's Ishrat Hussain and Brad Strickland will present the key findings of their 2018 report entitled Maximising Human Capital by Aligning Investments in Health and Education. We're also very pleased to have Professor Donald Bundy participating today as a co-presenter and discussant. Ms. Linda Schultz was the lead author of the report, supported by Dr. Laura Appleby, while Professor Bundy and Dr. Leslie Drake served as senior advisors. The report builds on important lessons in the World Bank's series Disease Control Priorities 3rd edition, sometimes called DCP3, Volume 8, as well as GPE's related joint publication with the World Bank. I think I've got it here to show you if you haven't already seen it. Optimizing Education Outcomes, High Return Investments in School Health for Increased Participation and Learning. Both of these publications highlight the added value of cross-sectoral coordination between health and education to enhance education quality. The report was funded by USAID's Bureau for Africa and analyses how health and education investments have the potential to maximise human capital in low-resource settings, especially if they are made in a well-timed and coordinated manner. If you haven't had a chance yet to check out our website today, do take a look at the blog on the title page this morning, which provides more information on the report. Today, our presenters are going to provide key findings from the report. They'll be sharing how investments in human capital, education and health specifically, promote human capital, economic sustainability, and promote a country's long-term self-reliance. They'll also discuss some simple health interventions that support equity and inclusion in education, both of which are vital to the development of human capital. They'll also discuss with the audience the operational implications of the findings in their programs. We'll also be looking at some next steps towards more intensified efforts towards human capacity development. Just by way of providing more introduction to our presenters today, I'll begin first with Ishrat Hussain. Ms. Ishrat Hussain is Senior Health Advisor in USAID's Africa Bureau. She's an economist and currently serves as Family Planning and Health Systems Strengthening Specialist on the Africa Bureau Health Team. She's responsible for handling the health systems portfolio, including health financing and reproductive health programs. Prior to joining USAID, she worked with us at the World Bank for over 25 years in technical and managerial positions. At the World Bank, she managed billion-dollar lending portfolios in health and population. She also directed the World Bank's policy work in health and managed its operations mostly in Africa and also in Bangladesh and East Asia. She's also active in various charitable and social service organisations. So we're very pleased to have you with us today, Ishrat. Secondly, I'd like to introduce Dr. Bradford Strickland, who is Senior Education Advisor in USAID's Africa Bureau. Brad, who many of you may know, is an international education specialist with long-term expertise in health and education programs, behaviour change, workforce development, and private sector partnerships. He began his work in international development at USAID as a postdoctoral fellow of the American Association for the Advancement of Science and was the Africa Bureau focal point for cross-sector programs in education, including HIV prevention and mitigation. He's continued working on health and education programs in NGOs and multilateral agencies based in Washington, D.C., including a stint with us here at GPE, and has supported education programs in a range of countries, including Afghanistan, Ethiopia, Haiti, Liberia, Malawi, Namibia, Niger, Senegal, South Africa, Uganda, and Zambia. So we're very pleased he found time to come back to GPE and be with us today. Welcome back, Brad. Last but never least, please welcome on the line from London, Professor Donald A.P. Bundy, a leading world authority on adolescent health and education. Professor Bundy was lead editor of the Child and Adolescent Health volume of the World Bank's 9-volume series, DCP3, last year, and as I mentioned, GPE's own related publication. Professor Bundy has worked in the field of international child health and development for 30 years and was the founder of the Partnership for Child Development, which is a civil society organisation that promotes health and education in more than 50 countries. He recently joined the London School of Hygiene and Tropical Medicine as Professor of Epidemiology and Development. Previously, he was Senior Lead Advisor for the Neglected Infectious Diseases team at the Bill and Melinda Gates Foundation and was also the lead specialist for health, nutrition and population for the Africa region at the World Bank. Don, it's great to have you back with us in this third webinar of the series. So if everyone is ready, I'll hand over to Ishrat to start the presentation. Is that right? Am I handing over to Ishrat or to Brad?
I'm going to set things up and pass to Ishrat.
I'm going to hand over to Brad. Thank you very much, Brad. Take it away.
So on your screen, thank you very much, Jane. On the screen, you'll see the title slide that announces, of course, the title of the report, Maximizing Human Capital by Aligning Investments in Health and Education. And just as a way, next slide, please, Sarah, of an outline of this presentation we'll be giving today, we'll talk a bit about the origin of the paper, of the report. We'll be looking at some compelling facts, findings in the report and key messages, and looking at the operational implications, and then have some broad discussion. Next, please. So, on the origin of the report, this report last May, June, July was conceptualized by Ishrat herself. The Education Division in the Africa Bureau and the Health Divisions had co-funded an activity that would look at the evidence to enhance outcomes in both health and education. And during the spring and into the summer, this report was completed, contracted by the Health Finance and Governance Project. Ishrat had conceived it to be in timing specifically with the World Bank's release of the Human Capital Index, and also it coincided with the publication of DCP3, the Child and Adolescent Health Volume that Jane has pointed out and GPE also worked on. The broad report itself was, as I think Jane's already given an excellent introduction to the lead author was Linda Schultz, supported by Laura Appleby, and Don Bundy was the senior advisor to the report and the project. And it was to look at the evidence in health and education linkages across the last 20 years and assess what is the evidence telling us about the importance of coordinating health and education interventions to enhance the outcomes of both the learning impacts and the health impacts. And Ishrat, I think the next slide you were going to talk with us about the USAID's journey to self-reliance.
Exactly. Yeah, thank you, Brad. As Brad mentioned, the origin of the report lies in the USAID's new approach of journey to self-reliance. What does it mean? It means getting ourselves out of business and reducing the need for foreign assistance. I really like it. That has been the dream for a long time of all development practitioners. The two pillars of self-reliance, as it has been laid out on the screen, are commitment and capacity. These two together, that is commitment and capacity, make the country advance towards self-reliance because most of the countries have this as an objective of their development programs. So one of the features of the capacity, as mentioned on the slide, is the ability to work cross-sectorally and obtain synergies for better results. And as you see, that this is the crux of this report that we are discussing today. Next slide. At the same time, as we have been discussing at USAID, the journey to self-reliance and capacity and commitment issues, the World Bank, during its annual meeting, announced the Human Capacity Index. And this is important as human capital drive human productivity and ingenuity that underlie all achievements, even in this day and age of artificial intelligence and robots. Yet, investment in human capital development has been grossly inadequate, particularly in developing countries, low and middle income countries. So to measure and highlight these inadequacies, the World Bank president at that time commissioned the development of Human Capacity Index. This was one way to show the countries where they stand. The index measures the amount of human capital that a child born today can expect to attain by age 18, given the conditions in the country where the child lives. The index is designed to highlight how improvements in current health and education outcomes shape the productivity of the next generation of workers, which is extremely important. So as the map shows, most countries in sub-Saharan Africa rank very low on this index, the lighter shade. And the big surprise to me, and so I think everybody, is Nigeria, which is 6 from the bottom, and lower than Sierra Leone, and slightly above Liberia. So we can see the extent to which human capital investment are required in the developing countries, particularly in Africa. So in view of these recent advancements at the World Bank and USAID, the two premier development institutions, we decided to commission a report which will provide evidence of health and education sectors, main sectors, working together to synergize the outcome in terms of human capital. So next. So the report starts by highlighting a few facts and give a few key messages, which I will go through very quickly. So the first fact that it highlights is that when health is at risk, so is learning. In low and middle income countries, almost 4 IQ points are lost due to worm infection and 6 points due to anemia. And as we all know that malnourishment is widely prevalent in these countries, and there are also other debilitating diseases. So one can imagine the loss of IQs and the potential just because of health issues. And we are highlighting only these two. And these two areas alone will amount to 2.5 years of additional schooling. So imagine just improving health, how much it will save the cost in terms of educational years. Next slide, please.
So in this, the report talks about the major cost savings that comes from working through schools or having schools serve as a platform for delivering simple health interventions. I think the GPE report, Optimizing Education Outcomes, also makes the point that the health sector isn't asking education to do everything. They're asking only for the education sector to open the doors to the school to allow for coordination of health activities in schools. There are some activities that teachers can do themselves, which are very cost effective. There are always more schools than clinics in rural areas and more teachers than health workers. And this slide that we're looking at now looks specifically at one of the key deworming, the cost issues around deworming are extraordinary, and the amount of absenteeism that owes to, and we saw in the previous slide, IQ points lost to worm infections. It's approximately 4 cents to deworm a student through schools, as opposed to mobile health teams, as the slide shows us, is approximately 51 cents, which is a 17 times more expensive than school-based interventions. Vision screening is another health intervention that can be done very cost-effectively through schools, costing approximately $3 per child per year, as opposed to doing it through mobile health teams costing approximately $8.17 per child, up to 4 times more expensive. So this is an important fact that the report is making clear, and the evidence that's in research activities and articles over the past 20 years makes these things very clear. I think Rachel Glenister next week is giving another webinar on the cost effectiveness of deworming interventions in particular and how it can increase school attendance. So we stay tuned to that evidence. Ishrat.
Thank you, Brett, again. As Brad mentioned, schools serve more people than health facilities. And health facilities, as we all know, are notoriously absent from many areas. Even community health workers on whom we are relying a lot for providing health services have limited capacity and coverage. In low-income countries, schools can reach almost 600 million school children. Early school-based intervention will have profound influence on productivity and earning. I think it is foundational. It could increase a person's earning capacity by 5%. Also, making schools as platform for health education has multiple advantages. It lays the foundation for health among children, and it educates the community, because the children, when they go back home, they can apply the knowledge that they had at their school. Recently, Peace Corps had a write-up on its program in one of the areas in Senegal, Kédougou area, and there the Peace Corps trained one motivated educator from each of 34 schools in that area in malaria, to prevent malaria. They tested hundreds of students and treated them and saved a lot of school days. And that, I think, is the type of program which one can promote, particularly on this malaria day. So these are the facts, but there are facts emerging. We don't have enough analytical work done in this area, but as the researchers progress, we will find out more facts supporting what we are talking about. So there are, next please. So there are 5 key messages in the report. First is that I don't know if it is clear enough, it's very small font. The scale and contribution of human capital to national economic growth and stability is significantly under-recognized. Human capital accounts for 70% of the wealth in developed countries, while it is only 40% in the developing countries. Human capacity alone explains a large part or half the difference between the developed and the developing countries. So there is a large unrealized potential of human beings. And once you start harnessing that potential, in my opinion, it has a compounding effect, because human ingenuity knows no bound. The second key message is effective human capital development requires synergistic investment in health and education across the life course. And I will also add that other sectors. So it's really a multi-sectoral program with focus on health and education, but agriculture plays an important role, as we saw that how important is nutrition for human capacity. A recent analytical work indicates that the life course is 8,000 days or up to 21 years. It takes that long for a human body to fully develop to adulthood and they to enter a productive labor force. The third, next one, the third message, that there are critical failures in design of current approaches to investment in human capital. Current investment in low and middle income countries is not only inadequate, but is not appropriately targeted. For example, the report quotes that investment in health of children under 5 is 29 billion, while it is only 3 billion in ages 5 to 19. And certainly there is a lot of balance that is required. One can argue that under 5 mortality was high and therefore that investment was required, certainly, but I think that as the mortality goes down, we need to have more balance in investment throughout the ages up to 21 years. Fourth, there is this, I can't read, is the fourth coming on there? Yeah. Fourth, there is a strong evidence that most cost-effective way to maximize human capital is by investing strategically, both in health and education. The strategic investments requires in all the 5 key stages of life. These are first 1,000 days, which I think UNICEF has been promoting for a long time, early childhood, school age, adolescent, and transition to labor market. And this is extremely important for the future, particularly in Africa, because without these kind of investment, the future generation would not meet the requirements of 21st century labor force. And for Africa, it is particularly important that in this century, late in this century, most of the labor force globally will come from Africa, because Africa will have a younger age structure than the rest of the world. And what I say is that not only the African prosperity, but the global prosperity will depend on the competence of African labor force. We already see how many health workers are coming from Africa and in other areas, and therefore the training of these workers at this time will define the future of the world. Fifth, there are key actions, the report dwells upon them a lot, that can be taken in the first 8,000 days of life to maximize the human capital. And these are both in health and education. They range from immunization to control of communicable diseases, prevention of non-communicable as well as communicable diseases. And so there is a lot that can be done at this time in a very cost-effective manner if we organize ourselves and if we have a strong will to do so.
Next slide, Sarah. So this slide is actually looking at some of the operational implications of the report. Certainly it has operational implications for USAID missions in Africa, also for ministries of education, partners in education and health, and also with World Bank and GPE investments in Africa. This notion of investing in human capital as a key driver of economic growth is an objective in many education sector plans, building human capital and creating a healthy workforce. It's very difficult to know exactly how to break that down, but the World Bank Human Capital Index does a very good job telling us, defining those terms, and it's very clear that education and health coordination would be a key component of the cumulative knowledge, skills, and abilities of youth and workforce. A second operational implication really is that one of the key targets, we've talked about this earlier, schools opening the doors to invite the health sector in. A school health framework in education isn't necessarily asking teachers or the school to do all the activities, but to open the doors for the health sector to bring resources and staff and personnel into the school place itself. This is largely about, when we think of the FRESH framework and other primary school health frameworks, a matter of local resources being mobilized to support education rather than thinking of donor assistance or World Bank funding to support the education sector to do this. No, it's actually health sector or other private investment opportunities within the education school place. Another operational implication really looks at the same point in many ways. The coordination between education and health is what's being discussed, not sectoral integration. One's not asking teachers only to do health activities or health workers to do education activities, but rather coordinate between the two and time the investments so that they really are maximizing education outcomes for the education sector and also health outcomes. Finally, the report does describe precisely how schools can provide a platform for health interventions and what are the necessary components of that school health framework, and actually what resources can be mobilized to train teachers, administrators, the education sector to bring the health sector into the school place. And that's a key operational implication, which requires actually very little resources. Isra?
Yeah, so I feel that the best practices are extremely important because they show us what is possible, what is not possible. But for me, it has an added advantage, and the advantage is that you can develop various business models from the best practices. And that is what I think we should be thinking of doing as we move forward with the coordinated approach to human capacity development. And I very much would like to underscore the word coordination, because much of the confusion comes from the word integration. I don't think that we are talking of the same budget or the same people trained in two different things, but it is really the question of coordination which is lacking. So Uganda, I think that our mission in Uganda, I hope somebody is on the call from Uganda, they did really the pioneering work. Their health and education sector were working together. And another, I think, new approach that they took was that they made a 14-year girl as the target. So whatever was needed for this 14-year girl to develop fully and participate in the community and contribute to the community, that is what defined the design of the programs, which was really very innovative thinking, and I hope somebody is there to explain it further. Then the second example is the usual one, which is about orphan and vulnerable children. And the PEPFAR program, I think, has been at the forefront of supporting orphan and vulnerable children. And here, I think what the model, I can say, shows is a comprehensive nature of the program. So the program covers psychological needs and sociological, as well as health, education, and economic strengthening, and so on. So that shows that how all these sectors can work together to help the orphan and vulnerable children. And PEPFAR and the program DREAM, which is focused on girls, and that also has a similar approach. So these things are working and can work if we really take appropriate actions.
So let's see, do we have Don Bundy on our line? Don, we were going to ask you to discuss the example of Nigeria, please, if you're there. I think, and also South Africa on this current slide.
Hearing me? No?
Yeah, we can now.
Now
I think
we're
you
hearing
come
you.
off mute now. Welcome, Don.
Okay, hi. Thanks a lot, Jane. That's super. Great to join you, and great to hear from Ishrat and Brad on this very important issue. It's a real privilege to join you here from London today. I just before talking specifically about these two examples, I just wanted to pick up on Ishrat's comment about the human capital and this remarkable finding that in rich countries like ours, some 70% of our wealth we can ascribe to human action, to the actions of our populations, of our people. But in poor countries, only about 40% of the wealth is coming from that source. And that's really gives two messages. First, that poor countries are wasting a very important resource. Their people are not able to make the contribution they could make. And secondly, that the people's lives are not being really given the real opportunity to achieve their full capacity. That people's capabilities are not being maximized by the opportunities that society should and could give them in terms of health and education. So I felt that Ishrat's point is a really important one, that it's that 40% figure that we need to worry about. Poor countries not getting enough out of their own populations, not giving their people a real chance in life. And if we look at the numbers there, this I find very telling. If we look at poor and so low and lower middle income countries, if we look at children over the age of 5, say between 5 and 18 in those countries, then the budget that's being invested in education is about 210 billion, and the amount we're investing in health is about 4 billion. A massive difference there, and yet we know that good health is crucially important for good education. And so that just highlights how far away we are from where we need to be on that. So I feel that's a very important point. You know, we're all used to talking about DALYs. DALYs first came out in 1993, but in 2018 we have a new metric called LAYS. LAYS means learning adjusted years of schooling. Learning adjusted years of schooling. And what that's saying is it's all very well being in school, but are you learning? And if you're not well, then the answer is you're not. And so the learning adjusted years of schooling is part of the metric of the human capital, and that's the one we need to get at from the health side and the education side working together. It's World Malaria Day. It's a great example, malaria, of a health condition that really impacts education. We know that cognitive ability is seriously affected by malaria. That's well shown in properly conducted trials. We also know that malaria is a major cause of absenteeism from school in areas where it's important. But what do we do for malaria in school children? I'm afraid the answer is very little indeed. That they've not been a focus, and they aren't a focus of malaria programs. So that's the kind of rethinking that I think we really need to do together. The education folks and the health folks need to think together about how schools can now respond to malaria, and let's try and do that on this Malaria Day. That's my introduction, if you like, to now turning to these two regional examples. These are two examples of countries that have really already taken on board many of these issues about linking health with education. And these are examples because they are chosen because they are large scale, because they're broad in scope, and most importantly, because they're actually supported by domestic finances. In other words, we have here two clear examples where countries can, on their own, run these programs out. Of course, there needs to be input somewhere along the road, but I just want to make it clear that we're talking about programs that are real programs. So let's take Nigeria. This is supposed to be an investment, and it's very interesting that it's the social protection side of the Nigerian government that invests in its school feeding program. 14 years ago, I was part of this. There was a first attempt to do school feeding as a broad intervention in Nigeria, and it failed. It failed because of the way in which the finances were managed. It failed very rapidly. But there were small pockets that held on, and those small pockets, and Osun State was one of them, they looked at how they could put in place cash-free systems to provide school health and school feeding. And 4 years ago, the government that came in reforming the social programs said they wanted to now use that model of Osun State and roll it out nationally. And 4 years later, they've gone from 1.2 million children being fed to, I understand the latest figure is 9.8 million children being fed. And that means 9.8 million children being fed every day during the school year. That's a huge number. And what helps me understand that number is if you think about, there's cereals and pulses and vegetables that are part of this. But the number of eggs involved in doing this is 6.8 million eggs every week. And the number of fish, because fish farming is an important part of this program, that's 75 metric tons of fish every week. It's a very big business, a very successful business that's now, as I say, feeding 9.8 million children, but it's also employing 98,000 caterers, 98,000 women who were previously market women with few opportunities for gaining money, are now full-time caterers in the system. We can talk more about those sorts of details. But this is a system now that's already well advanced in Nigeria. Switching to South Africa, and the program there is a program called Care and Support for Teachers and Learners. And this is a very comprehensive program, and it's also seen as an investment program. And in fact, it was seen as an investment program by the great visionary in thinking about investment in development, Nelson Mandela himself. In his first 100 days in office, he launched this idea of programs that would target the poor in schools. And today, this is a program that operates in all 9 provinces of the country. So it's a well-established, ingrained program, part of the system. It targets all children in the economic quintiles 1 to 3. In other words, it targets all the bottom 3 poorest groups of children, but all children are in fact receiving it. But the state actually supports the bottom 3 quintiles, and it reaches somewhere between 9.4 and 10 million children, which is all the children that come under that grouping. It's an extraordinarily comprehensive program that includes school meals, deworming, vaccination, vision screening, and health education, and sexuality education, and so on. It's a remarkable program, and it's a program like the Nigeria program that also has a very strong gender emphasis, because these kinds of programs, in fact, have their biggest impact on girls' education outcomes. So here are 2 examples of what can be done by countries themselves. So these help us. These are great examples because they help us in talking with other countries to show what can be done and what is already happening. So that's the main message I wanted to give you to share with the group. I think Ishrat and Brad, that's where you asked me to come in.
Exactly, but we also look forward to broad discussion points on this final slide. Saranat, if we could advance the slide. The final slide is looking at discussion points that we thought would be valuable for discussing in general among all of us. And I guess I would ask Ishrat to say something about the first discussion point, the contribution of human capital to national economic growth and stability, as our economist.
Seriously, yeah, we have already talked about it, but what to me is important in this discussion is what can we do? And also that if there is additional evidence of health and education working together, I mean, Dawn has quoted very good examples, and we have a couple of other examples, but if there are other examples that will provide us there is information as to what we can do next as far as our investments are concerned. And also, I think I would like to add a point here is that some arguments have been made that the teachers are overburdened, and therefore we should really be careful in adding another task to them. But my argument there is that the number of days lost because of illnesses also makes the teachers unavailable and reduces their productivity. So it doesn't dispute what I'm saying. It doesn't speak to the first point, because of the fact that we already have talked the contribution. But I would like to say here we talk, what do we do going forward?
So I guess that's actually a question to our viewing audience.
And one of course action I would suggest here is that there is need for greater investment in analytical work of contribution of human capital to economic growth. As Don rightly said, that the 70%, 40% difference is very stark. And if we dig further and find out as to why it is so and what can be done, I think that will be extremely important. So analytical work in this area.
Well, certainly, thank you so much, Ishrat, Brad, and Dawn, for really, I think, making a very compelling case for investing across sectors, not only health. I think that was important that you mentioned. Investing longer and investing more strategically, I think, at these particular moments in the life course. And all of these, this idea of the very comprehensive approach, if we want to fully develop the human capital potential of populations that are currently not being tapped, and achieve inclusive growth that benefits everyone. And I think another key takeaway was the gender equality benefits that I think Dawn outlined. I think you also mentioned that, Ishrat, that the benefits of investing in girls' health deliver not only education, better education outcomes for the girls themselves, but it has a ripple effect. I'm wondering if we have any questions from outside. We're not quite ready yet. Please do give us your questions if you're joining us on the line around the world. We would love to hear from you. But perhaps, while we're waiting for people to join in, I mean, if you're not quite sure how to join in, perhaps I should also mention that you can post your questions through the comments section under the video pane on your YouTube screen. We'll collect these and address them to the presenters. We'd love to hear your name and your institution and so where you're coming from. But perhaps while we're waiting for questions to come in, I'm just wondering, we heard a little bit, Don, from you about things that countries, two particular countries, Nigeria and South Africa, you mentioned, who are really taking this forward using their own resources. And I think that was the point that you made as well. If we have the will to do it, Ishrat, and organise it, then we can do a lot. Do you have any other examples, Don or Brad, of good practices that are happening, outside perhaps the school feeding?
Jane, a couple of specific things that I would like that might stimulate Don and others to also contribute. What can be done now? What are some examples of things we can do now? I think that's something we would like to hear from everyone in the audience as well. But there are two very concrete things that I know can be done to foster coordination between education and health sectors. One is helping the local education group, the LEG, actually dialogue around these issues, because very often one finds that there are no health issues mentioned specifically in an education sector plan, and that discussion always needs to be invigorated and supported in order for it to be a part of the education sector's strategy and thinking. Another thing that can be done with very low resource, if any additional, these are also things I would stress are done optimally with local resources without additional donor resources from outside, or a donor could support the activities. One is put a school health framework or a policy framework in the education sector. Very often, once one establishes the value of coordination between health interventions and learning outcomes, and there's broad agreement in the evidence that this is an important thing to do, well, then the sustainability of those activities is really important. If it's worth doing once and improving learning outcomes, it is worth sustaining. But that does require the education sector owning it and providing the framework for the health sector or other partners to come in and do the health interventions through schools or through education. And that school health framework is something that ministries of education, some ministries have fabulous school health frameworks, and they can foster one another and provide examples to one another. Uganda is a country that has a very strong school health framework. Kenya is another. Zambia and Malawi both have school health frameworks. The degree to which they're actually being engaged and used broadly across the education sector always needs to be examined and discussed on the local education group. So those are two things I would like to offer.
Yeah, I think that I absolutely agree. Also, I think that the community education is extremely important. If the community is empowered and given these ideas that the teachers and the community health workers and the health centers can work together to promote health, I think that will go a long way in bringing the two sectors together and taking advantage of the resources which are available locally. But health education is weak in most of these countries, and health education units are not really properly equipped to undertake those activities. So health education has to expand and has to be strengthened and start from the bottom up, start with the community taking advantage of the resources within the community.
Mm-hmm. Well, certainly I think that is really very promising, isn't it? That we can do things already to stimulate this dialogue, as you're saying, and take an appreciative inquiry approach. What is working well? What have we got? And what can we do more of? So, Don, I think you wanted to come in there.
Yeah, I think I was speaking on mute. One of the more popular things to do, isn't it? On these discussions.
We all do it, Don.
Yeah. So Jane, I really liked your re-emphasis on the girls' education issue, on the gender dimension to it. So recently, I was working with Canada on what they call the feminist development agenda approach to some of these issues, and the interesting feature there that I just wanted to highlight. Here's a number that really impressed me, and this was work by the Malala Fund with the World Bank, and it asked the simple question: what would be the value to the global economy of all girls completing secondary education? Right. So we're already well along the road on completing primary education. What if all girls completed secondary education? What would be the added value in terms of the extra training, the great extra human capital that would be created by that? And the figure is $30 trillion. $30 trillion. Now, that figure may be wrong. It may be only $3 trillion, or it may be only $30 billion. None of those figures are small. None of those figures are anything like trivial. So there's a huge issue here that is a massive return on investment. This is something that's just worth doing, quite apart from any rights issues and so forth. It's worth doing simply because of the huge return it would have to the global society. So I just wanted to share that one.
Very much, Don. I think this idea, as you say, we've got rights issues here, but we've also got smart economics, and in our sort of resource restricted world, we certainly want to use our resources as strategically as we can and get the maximum benefit. And it's I think, coming across to me very strongly that this is a smart way to use our resources. I'm getting a question here from Moussa Diouf from Senegal. And I'm not sure who the question is directed to, but perhaps I can open it to all the panel. How do you think you would be able to develop human capital, especially in schools, using this school framework? And secondly, does the report cover the situation in Senegal?
So the first question about the school, I think you can talk about it. I think the report does not specifically, to the extent I see, cover Senegal, but I just quoted the example of an experiment that the Peace Corps is undertaking, which is not in the report, but it came afterwards. This is a recent development where they are training from 34 schools teachers who are motivated to control malaria, and it has been a very successful program. So they immediately came up with a write-up, and now they are going to expand and strengthen that program. And as usual, Senegal is taking the lead in West Africa in that respect, which is really commendable.
So, it's correct, Ishrat. The report does not cover or address specifically the situation in Senegal. And I think one of the issues, the fresh framework, the fresh approach in school health does have a situation analysis to look at specific health interventions within a country. Don might want to say a word about that as well. for assessing what are the optimal activities that would improve learning outcomes in a given setting. I know that Senegal's school health approach is actually quite robust. The water and sanitation focus has been discussed at length, and I think a number of donor activities are also looking at ways to support water and sanitation, and specifically menstrual hygiene management for girls. The obvious thing to me about improving human capital within the school setting is the impact on learning outcomes. If those learning outcomes of school-age children aren't enhanced, then the money invested in education is clearly wasted. It is not used effectively, and a workforce, youth coming out and being prepared for active participation in the economy is not maximized. It's a real loss. So that combined, that is the definition of human capital in the World Bank's Human Capital Index. The combined cumulative scope of knowledge, skills, abilities, and capacities of youth. And I think it certainly is true that the learning outcomes through schools are enhanced by these school health activities. I think, Eleni, you were just pointing to the Senegal school health program. Jane?
Yes, I'm very pleased to come in here. I'm wondering if I can hand to my colleague, Eleni Papusa, who has been doing that survey that I mentioned in my introduction for us here in the Secretariat, looking at what countries are investing in terms of school health in GPE partner countries. And I think you looked at Senegal and found that the education sector plan there is working on health already?
Yes. They have activities on education policy, wash, nutrition, school feeding, and gender-based violence already.
So that's actually very interesting that they're including that gender-based violence. I think you mentioned, Ishrat, this idea of having to be multi-sectoral. So it's not just physical health, there are other types of health issues that need to be addressed. So interesting that Senegal's taking that very comprehensive approach and having some innovative approaches there. So I hope that covers that question. We've got another question coming in. We've got a number of questions. I think I'm going to hand this one to you, Ishrat, as the economist. What is the balance of limited resources, given that resources are already insufficient to fulfill all needs within the first 1,000 days? We're talking about 8,000 days now. So how do we balance what we have? Is the vision, so the second part of the question, and I think you've alluded to this, but I think people want a little bit more detail, is the vision for existing health workers to deliver services at schools or to train teachers to provide health services themselves? So two parts.
Yeah, I think this is a very good question, and I thought that those will be the questions will arise in the mind of the people who were without proper education. So the first part of the question with regard to the resource constraint, that is precisely the reason that we should maximize the synergies to use the limited resources well. The resources which already exist, these will not require additional resources. For example, I quoted the case of malaria, where the teachers themselves thought that the children are wasting time because of the various illnesses, particularly malaria, and teachers themselves are absent. So this is the waste of resources, and a little bit of effort to educate people how to prevent the mosquitoes biting and how to prevent the environment which will create malaria. That went a long way in improving the health of both teachers and students, and that can happen across the board. So what I would say is that just using the existing resources well means a lot in improving both health and education outcomes by using the prioritizing. For example, if malaria is prevalent, just doing a little bit to prevent malaria would be very, very useful. It would not require elaborate training. It would not require elaborate investment. It would just require the information as to what they can do in order to prevent this type of waste of resources. So that, I think, is the answer to your question, that with the given resources, we can do a lot. And that's the whole crux of this report, how to maximize particularly the current investment in both health and education for better outcomes. And that can be done, I mean, if you look at the schools and you look at the health centers. The second is not the service provision by the community health workers or the teachers. It is just a question of being aware of the factors that are contributing to ill health and preventing those. So it's largely a prevention program that we are talking about. I think, yeah, of course, if the person falls sick, has to go to the health centers, and then the resources of the professionals will be needed. But other than that, it is really what can be done at a low cost and not providing services, but it's a question of prevention.
So if I could John, come in
yes,
on
would you like to elaborate?
Yeah, I think that was a great answer from Ishrat, but I want to go back to, sort of some of the implications of the way the question was posed, which was about, the 1,000 days and the next 7,000 days. And, I was the lead editor on the DCP3 volume 8 that really gets into this issue. And we didn't set up the volume to come up with this question. But what we found was that once we started doing the analysis, then everything that anyone's ever said about the first 1,000 days is true. That's absolutely important. Getting the right start in life is absolutely necessary. But it also soon turned out that you couldn't simply stop there. And that the next 7,000 days, so that takes you up to about 19 or 20 years of age, that in that period of time, there's also a key need to invest. One of the reasons you invest is because you want to secure the gains of the investment in the first 1,000 days, right? Those don't just, making sure kids are fine by the age of 2 isn't enough. I mean, this isn't, as I say, when I talk to groups of people about this, who are not in this technical area, they just look at me as though I'm saying something that's perfectly obvious. If you're a parent, you don't think, well, now they're 2, that's just fine. And so clearly we need to sustain the investment throughout development. But it now turns out that there are actually very key periods in that second 7,000 days, periods which are perfectly obvious, like puberty, like the time when the main part of brain rewiring occurs in late adolescence. We have to, in those periods, make sure we're also dealing with health properly. So I think it's important that we realize that everything that was said about the first 1,000 days is right. So no one's speaking against the first 1,000 days, but we've really got to re-gear the way we think about this, because we're neglecting and removing opportunity if we don't maintain some interventions that go through the next 7,000 days. And the important point was that in DCP3, when we looked at the finances of this, as I alluded to earlier, in health, we're only spending about 4 billion in between the age of 5 and 20. So in that 15-year period, we spend about 4 billion. Before 5, we spend about 30 billion. So in the first 5 years, we spend 30 billion. In the next 15 years, we spend 4 billion. What's the change we need to do? Well, probably we need to double the amount we're spending in the second phase. So it's not trying to bring the 7,000 days up to the same level of spending as the first 1,000 days, but what we're doing now is just simply not enough. And any economist looking at the figure that we're investing 210 billion in educating children over 5, but only 4 billion in their health, anyone can see that then we need to rethink that, because the opportunity to leverage that 210 billion is there. And what we need to be saying is we need to get more engagement from the health community in thinking about those children in middle childhood and adolescence. That's the big piece that's missing.
Yes, thanks, Don. And I think, it's important that we're not saying, invest less in education, but we're certainly saying invest more in those later years in health. Sorry, Ishrat.
Yeah. No, sorry, no. What I wanted to add to what Don just said is that we have really done, the countries have done a remarkable job in reducing infant mortality, child mortality. So this investment really did pay off. And now as child mortality is going down, I think is the time to bring more balance. There is adolescent health program in various countries, but it is very weak so far. And therefore, I think it's extremely important to bring a balance that Don is talking about. And we have seen the consequences of this type of lack of investment. HIV/AIDS devastated the countries, economies. And if we had better health education program, probably we would have prevented so many infections and so many deaths in the prime stage of life. So we have examples of the consequences of not investing in that age group. And therefore, I think we should really take this step of bringing a more balance, which is really not a very high cost to infant prevention, but some increases there, and pay more attention to the health education program, particularly in these age groups.
Don, if I'm remembering correctly, you and Alice Albright, the CEO for GPE, co-authored an article in Lancet last April, I believe, that actually made the point that in the MDGs, the investment in under fives was the objective, but the SDGs that follow now are multi-sectoral and really a call to action for this coordination between sectors to accomplish outcomes that service both. Am I correct in my recollection?
Yeah, you're very much correct, and I think it's this idea that we've neglected the kids between 5 and 20, or the young people between 5 and 20. I think that's the real message here. And can I just say, Jane, no, I'm certainly not suggesting we should spend any less on education. That's not.
I was just underlying that you weren't saying that. I know you would never say that, especially in this world.
But it's also easy to make the mistake of thinking that what we're saying is that there needs, we need to invest in everything. That isn't the message. The message isn't that we need to invest in everything. The message is we need to continue our investment in the first 1,000 days in the way we're doing it. Maybe that even needs to be stepped up. But we also need to look at very careful investments in the next 7,000 days. And as I say, the costs there need not be very substantial. And we already have, and that's the point I would emphasize, we already have great examples of countries that are able to support those programs themselves. And it's the absence of those programs that's the problem. We simply aren't doing enough. And I saw Ishrat's face there where she was saying, we talk about having adolescent health programs, but in poor countries, they're really weak. They really hardly exist. And we have to change that.
Yeah, absolutely. I'm getting a few more questions coming in. I've got to think about 5 questions here. I have a question from Charles Omo from One. Morning, Charles. Thanks for tuning in today. Charles says, thank you GPE and W and World Bank teams for organising this webinar. I'm from Nigeria and I lead the team at Noble Missions, an education-focused non-profit. The question is, if educators in rural areas are still struggling with providing quality education, would this not be asking for too much if they have to incorporate some new health activities in their schools? And how would they be motivated to achieve this when challenges like poor remuneration, lack of resources and so on still abound, especially in a country like Nigeria? I think Ishrat, would that be one for you?
Yeah, sure. I think that this is a very good question. It's coming up again and again.
Yeah.
I think in the previous seminars,
Yes,
webinars,
teachers are already
it's
overburdened.
a real issue that the teachers are overburdened, underpaid, and don't have a very conducive environment to work, and therefore adding. But then my question is, can we afford not to? This is an absolute necessity because of the fact that the teachers and the students are also suffering from diseases which are preventable, which will improve their productivity, which will really make their life easier. And malaria is one of them, which is so highly prevalent, and also I think all types of cholera and other diseases, communicable diseases, which is spread because of the fact that the hygienic conditions are not proper. So I think that they can invest a little bit of their time to make their life easier. I think that is the whole point, and we all recognize the real issues that are there, but also I think one of the factors which is really reducing their productivity and making life difficult are the prevalence of various diseases.
Jane, I would like to remind ourselves that in the prologue to this book that was published by GPE last year, and again in the USAID report, the point is made that teachers are being asked. I think Don, in the original discussion around this version that GPE was doing, the question was asked, what is the education sector being asked to do? The education sector is being asked to open its doors, to promote the dialogue and help foster the capacity, the policy environment for that coordination to take place. It's not being asked to do all of the health activities. It's a matter of setting the stage for coordination and acknowledging that the evidence is very clear. Without addressing some of these basic health interventions, the children cannot learn. They will not learn effectively.
Exactly. Coordination is the key word. So, for example, the teachers, just take the real life situation. There are community health workers in almost all areas. And if the teachers just invite the community health workers to talk to school children and to teachers themselves as to what they can do in order to prevent various diseases, keep the environment clean, and wash hands, and so on and so forth, the basics. I think even that basic knowledge in many cases is lacking. So that would not place a large burden on the teachers. As a matter of fact, that will relieve them a little bit, and that will help in improving the community. And also, I think that the community health workers would be educated also, because they will find out from that discussion as to what are the factors that are hindering improvement in health. So it can be an advantage to both, and it would not be very costly in terms of finances or in terms of time.
And thanks for going back to reference to the report, Brad, because we do have a question, how do we get a copy of it? Is it available online, or
it certainly is available online,
online?
And I think after the webinar, the report will be posted online here, and also the PowerPoint in both English and French will be available. And it also is available on USAID's project website for the Health, Finance, and Governance project. But we can also make sure that it's available. We're disseminating widely to USAID Africa Bureau program officers, education officers, health officers. We're very happy to send it out if we can facilitate, but it will always be available here after this webinar.
And we'll make sure that the link is shared, I think.
And also, Jen, in terms of the resources to be available now, the bank has, after all these years, realized the importance of human capital and just not infrastructure, which has been, when I was there, was the main focus of investment. So now that the bank has come up with this index, and now they are developing the human capacity projects, $15 billion is planned by 2022 or 23, something like that. And so I think it will also be useful to take this report as a point of departure, but then also see what resources are going to be available from the bank and other sources, and take advantage of that in order to promote this sector coordination.
Well, that's absolutely right, and that's a wonderful segue into well, it's not actually a question, but it's a comment, and it I think encapsulates what you just said from Nuruddin Lawal, who is kind of flipping the scrutiny back to ourselves. We're talking about coordination as a very key issue that I think is emerging this morning between sectors in governments. But what about ourselves? Cross-sector coordination is important at the mission level as a model for the government. So how do we as organisations work more effectively in coordination with our different sectors? So I think that's important for our sense of, mutual accountability, that we need to be looking inwards as well as spreading the message outwards.
Jane, on that note, I do have to give kudos to Ishrat Hussain for helping to facilitate that bridge between the education and health divisions in the Africa Bureau. And we're always looking for additional ways to build that bridge across in USAID.
Yeah, thank you, Brad. I think your re-entry into USAID idea facilitated that as well. So
Catalyst.
But also, I think this is a very, very good question that we preach but don't practice what we preach. That has been a perennial problem with the donors. But to the credit of our missions, I think that, for example, I quoted the example of the Uganda mission. So Uganda mission for years has been working together, the health and education, and we are trying to give that as example for other missions to follow. But certainly, I think one big problem is these silos within health and the silos within the missions and everywhere. So it really requires a strong motivation to work together, because you have to really make extra effort. And we are hoping that this type of discussion that we are having now might give ideas and stimulate some interest, and we will continue to do so, because we need to have more analytical work in order to show the impact of coordination. Because I think that they need to see what they can get more out of this type of coordination, extra effort that they are making, how it is resulting in something which is better. The same thing goes for the schools and for the health workers. I think that the more we try to show the impact of these coordinated efforts, better off we will be in order to promote that type of approach and do the advocacy with the governments.
Absolutely. So having the evidence base to make a strong case.
Could I come in on that?
Yeah, I've got two more questions. But yeah,
sure.
Sure.
So one thing I just wanted to say was that if people wanted copies of the GPE version of DCP3 Volume 8, I'm sure they're available through your website, Jane. But
it's definitely on our website. Yes, we can definitely share that link. Thanks for pointing that out, Don. Yes, we will make sure that link is very clear. Thanks.
And I also just wanted to say that there is also the DCP3 website, which is www.dcp-3.org, where you can also download that and any other of those products that you might be interested in. But I do just want to make a quick comment on this business of coordination. Coordination really is about defining responsibilities. We had a great question from I think Musa in Senegal earlier on about the roles of teachers. Coordination. If we're going to have school health programs, then these cannot be a tax on teachers. This can't be a burden that teachers pick up. And one of the ways to deal with that is to view coordination as defining responsibilities and of doing that mutually. So if both sectors, both health and education, are part of the decision making, then this is a good way of avoiding the sense that one sector is preying upon the other or taking advantage of the other.
Yeah, that's a good point, Don. One sector preying on the other.
I think that's an image you're going to take away.
Don, I also think it's worth noting when you talk about defining responsibilities, how important it is to that a school health framework or policy framework. We're not talking about an empty policy discussion that goes nowhere. We're talking about defining responsibilities, and in very many cases, that's as simple as creating a paper trail so that there's evidence of what's been agreed to. If that isn't in place, then responsibilities are often just forgotten.
I think that is so important, isn't it? It's not coordinating sort of just to have a good talk.
Right.
It's to actually do something.
Exactly.
It needs to lead to something within a defined framework. Yeah.
I was going to say, and as Ishrat was pointing out, the other character in the room now for those discussions is the Ministry of Finance.
That's right.
Finance ministries are now expecting the sectors to work together because human capital is not gained by good health. It's not gained by good education. It is gained by both. And unless both work together, that's not happening. What we've got now is a mismatch, and so that's a real change that I think ministries of finance will rather push within the sectoral agendas. Anyway, that's my point.
That's exactly right. And Don, if that is any hit, I think several meetings of the finance ministers I've heard, they're talking about getting more efficiency, more synergy, and different sectors working together. But it just does not happen on this. It happens, I think, of course, we have these examples that we have quoted, there are many more. But then it does not happen on a large enough scale or national scale to make a difference. And that is where I think, Don, you are also right that we should also be talking to the ministries of finance because they can probably stimulate interest and make it happen.
Yes, sort of having some external pressure bringing to bear. I've got two more questions. I might perhaps deal with these together. I have one from Julio Santos asking what are the possible implications for curriculum choice, particularly in disadvantaged areas. And I think the next one relates to, this image of the health sector potentially preying on the education personnel. This is from Janelle Babb, who I think is with UNESCO. Yes. Do we have any research on the perceptions? I think this is interesting. Perceptions rather than numbers, but perceptions of education personnel from policy level through to classroom level on schools as platforms for health interventions, especially service delivery by education staff. So do we know how it feels to them to be in this? I guess some inside views. So I'm not sure if we do have any of that, because you've talked a lot about the need for more analytical work. Do we have any on this? So how education personnel feel about
and perceive themselves vis-a-vis health interventions. And I don't know, Janelle, I don't know that we do have enough evidence on that.
It's a good area to explore, isn't it?
It would be a very rich area for exploration, absolutely, and important for building a long-term sustainable pathway for health and education to work together.
Yeah, because if they're feeling resentful and feeling preyed upon, then it's not going to work.
Definitely.
In terms of curriculum choice, and the first question, I often think about the simple fact of creating a school health corner at a school in a library where there are health resources that students can go to for consultation. The school health framework that actually identifies very simple, easy activities like that are part of the FRESH framework. Janelle Bapp at UNESCO knows a lot about that, as does others who may be on the webinar. And those activities make the curriculum choices. That's the importance of having education sector dialogue around this, whether it's in the local education group or within the ministry itself. Without some school health dialogue, it's not very easy to define roles and responsibilities for schools and teachers.
Yeah, on Jenna's question also, the thing is that perception will differ. Perception in an area where mortality is high because of the preventable diseases, it will be a different perception than in other areas where there's no such problem.
Right.
And so I think it will be useful to really look at it from that perspective.
Contextual.
Yes.
And certainly a situation analysis to look at those factors within any given national framework or national context, but also a regional context is an important part of the FRESH framework also, which is our primary school focusing resources for effective school health, which Don Bundy also knows very well.
And I think that is such an important point, isn't it, about context, because in some places deworming will be critically important, in other places it's not the issue. HIV/AIDS prevalence is going to be greater or lesser in different places.
And there is a question of what can we do? What can we do? Yes, health is a problem they recognize, but they also do not know what role they can play.
No, and that's where you need the policy framework to give that guidance,
Exactly.
I'm guessing.
Could I say
yes,
could I
please,
say,
John.
just on the perceptions issue, I think it's a great question. And you know, Janelle, we should declare Janelle's real personal strong interest and experience in this area, because it is a good question. And of course, the answer to it depends very much on what has been the experience of the education sector. So if I choose the example of South Africa, if we talk about the program's called Care and Support for Teachers and Learners. And you'll realize immediately with that name, it's actually in the Ministry of Education. It's an education sector program. And it's an education sector program, but it delivers health. Not always delivering it by using the education sector. A huge piece of what they do is outsourced to health and other sectors and other groups. But if you were to ask within the CSTL team in South Africa, in the education team, they would have a clear view of what your question meant because they've got a real program to talk about. But it's those, if we talk about perceptions from those countries where there isn't a program, then I think what you find, and I think what's a normal expectation, is reasonable fear and apprehension from the education folks that they're going to be having to do the work of the health folks. And it's really, these are the kinds of barriers that need to be dealt with. And that's when I was saying how important it is that the partners need to sit around the same table and discuss these issues together.
Great. Well, thanks very much for that, Don. Oh, I'm getting, I think, one more question coming in here, which is from, and I do apologize for my awful pronunciation, Esi Kwao from American University of Nigeria, implementing the USAID-funded Addressing Education in Northeast Nigeria project for Adamawa and Gombe State. Thank you so much for your question, which is, this is really interesting. I think we've been alluding to it, but perhaps we've been looking at it perhaps from an individual angle rather than an institutional angle. Won't this coordination lead to friction between the education and health sector? So I'm wondering if that's alluding to budgets, perhaps. We haven't sort of quite touched on that yet, as well as institutional boundary issues, maybe. But I don't know. Would you like to, Ishrat, you're nodding, so maybe you'd like to take that.
I'm saying it's a great question, and there is a danger of that kind of a thing if it boils down to the budget, competition in the budget. But once that is clear, that it is not about the budget, but it is really using whatever you have effectively so both sector benefit. So it's a question of how this thing is presented, but certainly I think that is happening and there is real danger. Although one of the studies in Ghana we did, they say there is no hydraulics between education and
no hydraulics.
So in that case, I don't know how what this thing is. But certainly there is danger, and I think that the way we present will be very important.
Right, so it's a question of how things are done.
I think that's also worth just mentioning the sustainability that's its question in this. If there isn't some coordination between the two sectors, if health is trying to use education to accomplish any of its outcomes, but doesn't have a broad school health approach to hang that on, there's no reason to expect it to continue. And the health sector only improves its own chances for success and sustainability by coordination with education, and vice versa. If education outcomes aren't coordinated with health sector, there's no reason to expect those to sustain. So for purposes, for USAID, the journey to self-reliance and youth integration in programs both give us strong impetus for coordinating these two sectors together. And I think in terms of Ministry of Education's own objectives, building human capital and creating a healthy workforce, there's every reason to coordinate to accomplish those goals. And it would make the tension or friction between the sectors dissipate if they realize that working together, they make their own jobs so much more effective.
Yeah, I think that is really a very powerful message, that everyone wins.
I think that's where one can, I think, the term learner is not one we've been using, but we should. At the moment, we think of education systems as investing in learning systems primarily. We talk a lot about schools and a lot about teacher training and textbooks and curriculum and so forth. What we're trying to say here when we're talking about human capital is that there's also the learner in this system, and that if the learner isn't able to learn, then all of those investments come to naught. So I think a very key way to think about these investments is not to think about them in terms of health outcomes, but to think of them in terms of learning outcomes, and that investing in the learner is the key element there. And who does that investing and who pays for it is the area of discussion. That's the area of discussion. But for the educator, there should be no question that ensuring the learner is able to learn is a key part of the strategy.
Absolutely. If it's not about learning, then we're in the wrong business, really. So thanks for that, Don. I'm not getting any more questions. I would like to thank everyone very much indeed for very rich and probing questions, as was the panel for your insightful answers. I've certainly taken away a lot, I think, here. I'm not quite sure how I'm going to summarise it, but I guess one of the key things that I'm taking away is just the scale of the contribution to economic growth that human capital makes, or can make, and then there's this enormous untapped potential in developing country partners, making it, they're only really getting 40% of their wealth from human capital, and they could do so much more with that. So I think that really leads us to the point. It's not like why invest, but we can't afford not to do this. Is what I'm really hearing. And we've got investments in health. We've got investments in education. We're not synergizing them to the maximum that we could be. And I think, and related to that, you mentioned the importance of targeting those investments at strategic points in the life course, and balancing our focus. We've really done quite well in the first 1,000 days. We need to do a lot better at the next 7,000 days now to build a whole human being, is what I'm hearing. We talked a lot about coordination. But it's not just coordination for its own sake. That's got to be within a policy framework which defines roles and responsibilities. Who does what? I think that came up time and time again. Who's doing what? And are we going to make teachers do more things? And they're already doing so much, and they're overburdened and they're underpaid. And it's just not fair, and they feel that this is an extra tax on them. I think you used the word tax. And it really isn't about that. It's about defining the roles and responsibilities, and it's about using the school as a platform. I think you've said that a number of times, Brad, that it's not teachers doing everything, it's inviting the health system into the school, given that there are more schools than health centres. And that's a cost-effective route to health. It costs a lot less to do it that way. I think, we talked a little bit about, having that policy framework, but that's got to lead to action. And we talked about, I think, the potential for the Ministry of Finance to be a key actor in helping to move this agenda forward. And I couldn't possibly finish without mentioning the huge significant impacts to gender equality of these types of synergistic investments, which, as you've mentioned that, Don, it's not only a benefit to the girls as learners themselves in their own right, enjoying the right to education, but also that ripple effect that comes intergenerationally down through their families. I don't know if anybody wants to make a final word.
After your summary?
Only to say thank you, Jane, to
thank
you, to GPE for inviting us to be a part of this knowledge exchange webinar series. We're very pleased to have an opportunity to talk about the report from USAID Africa Bureau and Health and Education Divisions, and thank you.
Well, thank you very much to our wonderful panel. Thanks to the webinar team. And most of all, thank you to our listeners all around the world for being involved. And we wish you great success in your future work, coordinating these two sectors and beyond. And if you have any good practice stories, we'd love to hear from you. Thank you.
And thanks to Dawn.
Yes, Don, thank
Don,
you.
we're thanking you too. You were
Thank you.
the thanks.